Aloha, everyone, and thank you for those kind words of introduction. Cancer, one of the most feared and loaded words in the English language, and with good reason. I'm going to share with you a few statistics. I promise to keep it brief. 1 out of every 2 women in the United States will have a cancer diagnosis at some point in their life. 1 out of 3 men. Last year, there were about 7,500 new cancer cases in the state of Hawaii. And around 2,500 people died from cancer last year in this state. We have about 70,000 cancer survivors in the state of Hawaii. Now, sarcoma is a rare cancer, but it is often very, very serious. My wife is an orthopedic oncologist, and she takes care of many sarcoma patients. Some of them do well, some of them don't make it. A lot of the surgeries she does are very radical in nature. So this is an important disease. It may be a rare disease, but it's still very important and very impactful for those who are diagnosed with this form of cancer. Now, the good news is on the cancer front, we have doctors like Dr. Morita and others who are making real progress in improving cancer care outcomes. And so even if people have a diagnosis of cancer these days, they are more likely to survive than has been the case in years past. So that's the good news. And I am very impressed with the work I see going on here at the Cancer Center and all of the wonderful faculty who are engaged in the research that will lead to more cures and better outcomes. So I welcome you to the presentation tonight, and I hope you learn a lot. Thank you for having me.
Thank you, Dean Shoemaker. We know how busy you are. You just started July 1st, and for you to take the time to come here shows how important and interesting the interest that you have in this topic. As Dr. Shoemaker said, sarcoma is a major problem. It's very difficult to treat. We have survivors in this room. We have caregivers in this room. We have those of you online who have been affected by it. You may or may not know someone with sarcoma, but you can help someone. You can learn about what are the signs and symptoms and how to detect it. And you'll see through some of the speakers that we have that we may have a higher incidence of sarcoma than the nation. And I know Dr. Hernandez will go into further detail. Why do we choose to do this? You know, July is Sarcoma Awareness Month, and we wanted to make sure that there's a platform, and we are just ecstatic and just humbled by the Friends of UH Cancer Center who has continued to provide the support and this opportunity for the public to learn about various cancers in this Quest for the Cure series. So really want to thank all the stakeholders, all the different coordinators and folks that really have taken the time. Thank you to Michelle and Esme, and of course, Dr. Ueno, who couldn't be here, but you know, he really is someone that has a passion for cancer, obviously not only in the research realm, and the scientific realm, but as a patient himself, as many of you know, and he's public knowledge that he's a sarcoma survivor. You know, he's out of town, but you know, we need to understand that nobody is immune from cancer. We all can be affected. My father had cancer, and you know, we went through a lot of I would say trials and tribulations. So thank you for all of you who are here. Your bravery is commended. So I want to just start up with a few slides here. So we're going to talk about really why the call to action? You know, I've been back over 15 years now and just had an opportunity to just take care of so many wonderful folks. And we've really developed the critical mass. And as you learn that sarcoma is very rare, but it's still extremely important. And it's something where we really want to develop a forum, a platform for all of us to connect. There are people online I know that are participating. There are patients that I've talked to, and so, you know, the ability to connect with one another is so important. Everybody has a testimony, a story, and so it's really important that, you know, we connect and we share and just build community and build our network. There's a lot that we can do in Hawaii, although it's a small state. You know, it's so diverse, and we can answer questions that maybe other folks in the country can't because of our unique populations. So really my call today is to see if you're interested in being part of what we're trying to do, which is eventually having a sarcoma alliance. You can see that there's other foundations across the country that have one, but I think for our state, it's very important. We get a lot of patient referrals, and Dr. Kelly and and Dr. Will tell you from the rest of the state and neighbor islands, it's very challenging with the coordination, but together we can do anything. You know, we have wonderful partners with various health systems, including HPH, Queens, Tripler, Kuakini, Kaiser, you name it. It's everyone, and we need everyone's support. We need government. We need you know, the various hospitals. We need just various partners here. We have American Cancer Society. We have Compassion for Caregivers. Various different, you know, organizations are willing to partner with us. So it's extremely important. Sarcoma, as I mentioned, is very rare. It's only 1% of all adult cancers. And again, Dr. Hernandez will elaborate further. It's thought that we have it's estimated in the nation over 13,000 of soft tissue sarcoma, and Dr. Kelly will go into how much osteosarcoma is. And it's extensive anatomic location. It can be anywhere on the extremities. It can be in the abdomen. It can be on the scalp. And there's diverse number. There's over 100 different types of sarcoma. So it's a very challenging cancer to treat. And you'll hear not only from various clinicians here, physicians who take care of patients, but you hear from caregivers today and survivors who have gone through just a very difficult journey. This is a patient that was referred to me who said, you know, I'm not sure what's going on. I have some abdominal discomfort. And so this ended up being a sarcoma. So this is about over 40 centimeters. And for those of you who may not be as familiar with the metric system, you know, about 1 centimeter is about 2.5 centimeters is about an inch. So it's a pretty big tumor. So he needed surgery. You can see all this area here. That's all sarcoma. It shouldn't be there. Okay, and this is the liver here. So it's a pretty difficult operation, but he did well from it. But it can be something where if you notice something where someone's abdomen is growing, or you notice any kind of differences, please encourage them to seek further care. This is another patient who had a different type of sarcoma. That was a liposarcoma, a fatty tumor. This patient had a GI stromal tumor, and he's 29 years old when he was diagnosed. That's 29. Again, nobody's immune from this. So what you see here on the left is a PET scan, and we use that quite a bit in cancers to determine the activity of it and to see if there's any types of spread in other parts of the body. This ended up going to his liver. Again, he needed surgery and he needed additional treatment that you'll hear from Caroline Huff and what she's had to go through. So my only plea is early detection is important. If you know of any person who has a lump, a bump, something that's not getting better, please advise them to seek care. And I really want to thank all of you for being here today. I know it's during the week, there's a lot of different priorities, but it's so important that we all come together and listen to everyone's journeys. You may learn something today that will save someone's life. And here, not only my family members who continue to support me, but I have a wonderful team that I want to give a shout out to Trisha, Judith, Kelsey, and Yoshi. They're the ones that help bring the patients to me and take care of all the details that I don't have to do, and all I need to do is worry about operating. But so everyone needs a team, just like how when you have gone through, your cancer treatment, you need a team. And again, you hear from various speakers. So without further ado, I wanted to call up Dr. Brenda Hernandez, whose pedigree is just impeccable. She's trained at Harvard, then Yale, and we're so fortunate to have her here in Hawaii. She is a professor here at University of Hawaii Cancer Center, and we've collaborated on multiple fronts before. And she's an epidemiologist, and she oversees a Hawaii tumor registry, which carries a lot of data. And with that, she's going to share with you what's germane to Hawaii in sarcoma. Thank you, Dr. Hernandez.
So I'm going to be providing you just an overview of sarcoma in Hawaii and showing you some of the statewide statistics that comes from the Hawaii Tumor Registry, which is the entity here in the state responsible for surveillance of all cancers diagnosed in the state, including lifetime follow-up, so that we can know the outcome in terms of survival outcomes and other aspects of the cancer. So each year in Hawaii, approximately 155 residents of Hawaii are diagnosed with some form of sarcoma. And this is a very rare cancer, accounting for, among adults, only 2% of all cancers in adults. And it is more common in children overall, with accounting for about 13% of all cancers occurring in children and adolescents. Overall, the survival statistics, the survival for sarcomas, when you group them all together, are 68% in terms of 5-year survival. However, as Dr. Morita alluded to, early detection is really important. So we see a wide range in terms of survival by stage of diagnosis. So in general, the earlier the diagnosis, the better the survival. For example, in general, for localized sarcomas, the outcome in terms of survival can be upwards of 85%. So this shows you the age distribution in terms of individuals who are diagnosed with sarcoma. And this data comes from the period 2017 to 2021. So you can see that sarcomas in general are pretty rare among children and adolescents. The peak age of diagnosis is in the mid-60s. And so there is very, very similar to you see for a number of other cancers where in general, the older you get, the risk of cancer does increase. One of the challenges with sarcoma is that because it's such a rare cancer, in terms of research, it's very challenging to do, especially population-based research, epidemiologic research, because the numbers are so small and the cancer is so rare. And so one of the challenges definitely is in the terms of defining what is the etiology, what are risk factors. When you have more common cancers, for example, like breast cancer and prostate cancer, because we have a large number of cases that occur each year, it's much easier to be able to ascertain risk factors for those cancers. But other than age, there is very little we know in terms of the risk profile for sarcoma patients. So sarcomas in general are largely classified by the site of origin. So they can occur anywhere in the body, as Dr. Morita indicated. In general, we see they could occur, for example, in the lining of the blood vessels or lymph, including angiosarcomas. Sarcomas that occur in the bone include Ewing sarcoma as well as osteosarcoma. When they occur in the cartilage, they include chondrosarcomas. Those that occur in fat cells include liposarcomas. Those originating in the connective tissue include fibrosarcomas. And the most common sarcoma that we see here in Hawaii, as well as nationally, is our gastrointestinal stromal tumors, also called GIST. And these are mesenchymal tumors that occur in various parts of the body, but largely we see them most commonly occurring in the stomach and in the small intestine. So this shows you the same data from 2017 to 2021 by distribution of types of sarcoma. So you can see that GIST or gastrointestinal stroma tumors account for 1/4 of all sarcomas newly diagnosed in the state. Followed by carcinoma sarcomas, which are actually a mixture of carcinomas and sarcomas. Leiomyosarcomas account for 9% of sarcomas. And you can see the distribution of other types of sarcomas. So again, this really doesn't underscore, if you think about 155 cases occurring each year, that is very rare, because we see 7,700 individuals here in Hawaii newly diagnosed with cancer. So it's only a fraction of new diagnoses. So a major challenge in terms of research is really being able to ascertain the risk profiles of patients with such limited numbers. So when you compare our incidence here in the state overall, if you look at sarcomas, when you group them all together, our incidence rates, and this chart shows you the incidence in Hawaii compared to the rest of the US from 2017 to 2021. And you can see that when you group all sarcomas together, overall, Hawaii does have higher rates. However, statistically, the rates are not much higher than the US overall. However, when we focus specifically on GIST tumors, we do have significantly higher incidence of GIST in Hawaii compared to the rest of the US. So we will have Caroline specifically talking about some of her experience with her GIST diagnoses, but as with other sarcomas, we know very little in terms of the etiology of GIST. And that's where I want to end there and just really underscore the challenges that we're having in terms of being able to establish studies, especially population-based studies here in Hawaii. Some of the research that is going on in other parts of the world have shown geographic differences as well as differences in terms of demographic profiles. So for example, there is some national data showing that there are differences by race and ethnicity, with higher rates of GIST, for example, in Asian and Pacific Islanders, as well as in African Americans. However, we're not able, because of our small numbers, to really ascertain differences by race and ethnicity. So I will end there, and I will be able to take questions at the end of the presentations. Thank you for your time.
Thank you, Dr. Hernandez. That was wonderful. It's really important to understand what we're doing in Hawaii and just see some of the different trends and patterns that's observed that are quite different from the rest of the United States. I'm going to bring up Sean Kelly. He's a orthopedic oncologist. So I gave you an overview about soft tissue sarcoma, but I know Dr. Hernandez had a lot of information about that. But I wanted to also emphasize that osteosarcoma is also a type of sarcoma that we see not as often, but it tends to affect children more than adults. But I'll have him give you an overview of how he treats it surgically. So thank you, Dr. Kelly.
So yeah, a little different. I'm an orthopedic oncologist. So my training specifically is in treating bone sarcoma and metastatic disease. But want to thank Shane for all the work he put into today. So thank you, Dr. Morita, for giving me a chance to talk today. So osteosarcoma is quite rare. So there's 5 new cases per year for every 1 million people. So if you think of Hawaii, there's probably 5 to 7 cases per year. And so it's very rare. And so it's typically found in younger patients. So we're talking about the second and third decade of life. So we're talking adolescents and also young adults in their 20s. And so it's typically a lesion that you see, and this is an MRI showing basically the distal aspect of a femur or the thigh bone, and it's encompassed by a tumor. And so it's pretty large as far as what it affects and how destructive it can be to the joint and the surrounding tissues. And so what causes this? So there's very few actual risk factors. Most of it is just a one-off. However, there are a few that do exist. So people have pre-existing bone conditions like Paget's disease or fibrous dysplasia, patients who've had radiation treatment. So that's typically patients with previous cancer already. And there are a few inherited disorders like Rothman-Thompson syndrome, Lee-Fraumeni, and retinoblastoma. And you can see the image in the bottom right is a child who's lost the red reflex after a tumor is filling basically their eye. And so there's a few risk factors, but generally these just all arise de novo without any known risk. So what's the role of surgical treatment? So this is an avocado, and I think it's a good demonstration of how we look at these. And so osteosarcoma is chemosensitive, but it also needs a substantial amount of surgery to clear it. And so if you look at the pit of an avocado and think of that as a tumor, right? If you just remove the pit, which is circled in red, you're still going to have microscopic amounts of the pit left behind that can grow back. And so instead, this blue boundary is kind of showing the edge of what you have to take out in order to surgically clear the osteosarcoma. And so we talk about margins, and so there's intralesional, and this is when you do a procedure and you're basically removing the part of the tumor itself. And so that's the pit of the avocado. A marginal resection would be taking out the mass itself. And so this would be just removing the part of the cancer itself and not the surrounding tissue. And then our goal is a wide resection when you remove the portion of the tissue around it. And then certainly radical resection, which is part of what we talk about in these osteosarcomas, is when we remove the entire compartment, including the muscle, sometimes even an amputation itself. And so the types of surgical treatments, so there's limb preserving treatment. And so this is a patient in the middle who had a osteosarcoma of their pelvis. And so the resection was taking part of the pelvis. And so these are pretty drastic surgeries. And then you look at the one on the left side of the screen, the right for you. And that's a patient who had this distal femur or the lesion around the knee. And it's actually removing half of the femur bone and replacing it with metal. So it's basically a metal femur with a knee replacement on the end of it to allow the patient to walk again. Additionally, there's amputation. And so some patients aren't able to have their limbs saved, and that's not necessarily a loss. Amputation can actually be very functional. So when you think of someone who gets back to running after cancer, oftentimes it's an amputation as opposed to the limb preserving surgery. The downside, obviously, is you need to walk with crutches or with a prosthesis. And so we look at this, and most of the data we have in this is about trauma patients, but looking at prosthesis versus amputation. And overall, it's not different at 2 years. And so despite the fact that patients don't have the limb anymore, they still overall do very well. And it's actually the biggest debate is which one is more cost effective for the patient. And limb salvage is actually a little bit easier because you don't have to pay for a prosthesis every year. So the cost of those can add up pretty significantly. But the steps of surgery itself. So what do we do? So the first step is getting the important structures away. So that's saving the nerves, the blood vessels, and getting those dissected away from the tumor. The next step is actually removing the tumor. And so this is the part of the surgery where we use CT scans or radiographs to actually measure out where the tumor is. And then we use other surgical instruments to actually remove it. We'll look at the edge of the bone and the edge of the tumor to make sure it's completely removed. And then we reconstruct, and that sometimes involves plastic surgery for flaps and additional soft tissue coverage. And then the recovery. So these are major surgeries. And if you could imagine, the hospital stay of 3 to 10 days is just the start. And so it requires months to even a year of outpatient physical therapy and inpatient rehab to get that strength and ability to walk again. And postoperatively, many patients have chemotherapy, and infrequently radiation is part of this journey as well. And so surgery does have risks. So some of the risks we look at are wound healing complications. That's why we give antibiotics, and we have specialized wound dressings with vacuum assisted closure, as well as silver coated dressings to help reduce that risk. Nerve injuries, and so obviously dissecting around bones, it's a concern. Most of those, if they happen, it's a 6-week recovery. And this is generally debated and kind of discovered during the surgical plan, where a patient will know ahead of time what kind of neurologic changes they may have because the tumor invades a nerve, for instance. And then pain obviously is a huge part of this recovery. And so multimodal treatment involving pain management doctors and making sure we can get patients pain-free and back to life and back to walking as soon as we can. And then the last thing we worry about is recurrence. And so we do the surgery, patient recovers. We have 1 year of recovery and they're doing great. And then there's still this journey of a 5 to 8 year follow-up where we follow with scans and make sure that we're out of that window of recurrence. And so what does that look like for patients with bone sarcomas? Generally, it's the first 2 years, it's an MRI and CT scan every 3 months. Oftentimes we'll get a whole body imaging or a bone scan once a year. And then as we graduate forward, we start to space that out. And so we space it out to 6 months and then annually. And depending on the specific cancer, it could be 5 years, 8 years. Some of these are watched for 10 to 15 years as well. And so there's an example of what a bone scan is in the whole body imaging. So what are the future directions for treatment of osteosarcoma? Certainly for surgery, we're looking at 3D printed implants. And so we can create custom implants for the patient to give them the best chance of recovery, as well as navigation. So using intraoperative CT scan and computers and robotics to improve the margins that we're going for to save as much tissue and to make sure that we have all the cancer removed. Here's an example. This is a 3D printed pelvis that was used for a patient. The pink cylinders are the screw trajectories and the kind of yellow orangish color is the metal implant itself. And as far as medical treatment, I know Dr. Wu's probably getting this, but certainly immunotherapy is on the horizon. It hasn't had the best outcomes for osteosarcoma. CAR T has also been looked at, which is when you engineer your own immune cells to fight cancer. And lastly is mRNA vaccines like the COVID vaccine. And we're actually trying these in dogs right now. So hopefully that'll make its way to humans if it works successfully. So in conclusion, osteosarcoma is a very rare cancer. It's treated with a pretty extensive and wide surgery. Chemotherapy is a big part of treatment. The research for this has been limited. And so, we're still at the early stages of figuring this out, but it's definitely increasing. There's new treatments on the horizon. So I'd say it's very humbling and it's an honor to be here in front of all these patients and family members to see all the interest garnered. And I hope this continues to move forward in new directions for us. So thank you.
Thank you, Dr. Kelly. I'm from Queens. Dr. Kelly's primarily a tripler. Dr. Wu, even though we are different institutions, we all collaborate. It's a very small state. He's at Hawaii Pacific Health. He's a medical oncologist. And so sarcoma to me is really the epitome of a type of cancer that's really, it's taken care of by what we call multidisciplinary team approach. It's surgeons, it's radiation oncologists, it's medical oncologists, navigators, all sometimes palliative care, pathologists, so important, radiologists. So he's going to talk to you about how systemic therapy, i.e. drugs, different options can be used for sarcoma, because sometimes sarcoma can't really be treated only with a scalpel, like with what Dr. Kelly and I do. So without further ado, Evan, thank you so much for taking your time and coming and share your wealth of knowledge.
Okay, so thank you, Shane, or Dr. Morita. And I think this will just go a little bit onto what everybody else, especially what Dr. Kelly was talking about. So I'll give you a little bit of an overview. So what I like to start with whenever I see a patient is we have 3 different types of cancer doctors. So you have a surgical oncologist, a radiation oncologist, and a medical oncologist. And they're actually listed in priority of importance. So surgeons are number 1, radiation is number 2, and then number 3 is your medical oncologist. And I truly believe that for sarcomas. So I tell them for sarcomas, your most important doctor is right there, okay? So find the best surgeon possible. You have 2 here, but I would get the best surgeon possible. Then if after that, you would find the best radiation doctor. And then if you have the best radiation doctor, then your medical oncologist can be whoever you find, okay? So that's what I truly believe. And I'll tell you a little bit more about it, why. But so for medical oncology, what can we actually offer you in sarcoma? It's actually true across all cancer types, okay? So there are three main types. Chemotherapy, so chemotherapy, I'll go over a little bit more. Immunotherapy, and then targeted therapy. So those are our three different kinds of treatment options across all cancer types, sarcoma included. Okay? And I'll just preface this by saying that most of this is about soft tissue sarcomas because I didn't know if Dr. Morita mentioned this, but I'm an adult medical oncologist. So pediatric medical oncologists typically treat the osteosarcomas, the Ewing sarcomas, whereas we treat the soft tissue sarcomas, which happen more in adults. So some of this will be tailored towards soft tissue sarcomas, but some of it overlaps as well with bone sarcomas. So chemotherapy, the way I describe it to patients, which they hate, is it is poison to your cells, okay? And unfortunately, sarcoma for the chemotherapies we use for sarcomas are actually, they match what a lot of people think about chemotherapy. You lose your hair, you vomit, you're sick, you're really sick, you're prone to infections. So these are poison to your healthy cells, but they actually preferentially kill cells that are dividing. So that's what we call chemotherapy. Now, the only thing that chemotherapy is a little confusing because it can be given, we typically think about it as intravenous or injections, but it can actually also be given subcutaneously under the skin. It can be given by mouth. So we do have oral types of chemotherapy. But the general idea is that they're trying to kill all the cells in your body, preferentially your cancer cells. Okay. So this table is not meant for anything besides just showing you that in the national cancer guidelines that we all follow in the United States, we have a whole bunch of different regimens for soft tissue sarcomas, okay? And I'll go over some of the very basics, but here's kind of the main thing. So if you look at the first line therapies for advanced metastatic soft tissue sarcomas, which is how we end up seeing most of these patients, because again, number one is surgery. So I see a sarcoma patient, the first thing I ask myself, can you do surgery? If you can't do surgery, the second thing I ask myself is, can they do radiation? And then if they can't do radiation and they can't do chemo and they can't do any surgery, then they fall to my lap and all I can offer them are these options here, okay? So these are kind of this hodgepodge of different kinds of chemotherapy medications, but I would say the general theme for all sarcomas, soft tissue sarcomas, is something called anthracycline. It's not too important to understand what it is, but this is what it looks like. So once you see it, you'll never forget. In the hospital, it looks like a very, very red, bright, it's not blood, it's called, they call it the red devil chemo. They called it that forever, but it's doxorubicin. There are different varieties of anthracycline, so you might see something doxorubicin, liposomal doxorubicin, epirubicin, but they're all different kinds of anthracyclines. They all look reddish, and they're all actually very toxic. So the other one that you hear a lot about, and it's a very promising drug in other types of cancers. I'll show you some data on soft tissue sarcomas, but it's called immunotherapy. So immunotherapy, it's very confusing because it's a very umbrella term. So immunotherapy means any type of therapy that revs up your immune system and uses your own immune system to kill cancer. So sounds great, can work really well. The most common types of immunotherapies we see are things called checkpoint inhibitors. So they block this pathway that the cancer cell has to evade the immune system. You unleash that brake, and then all of a sudden you can have your own cancer cells, your own tumors, your own T cells, your own immune system cells kill the cancer. So we say it's using your patient's own immune system to cancer. So here, going back to this huge table, there's right here in the bottom right corner, you'll see there's a role for immunotherapy for some patients. But if you notice, it's actually just for the subsequent lines. So we actually don't use it in the frontline setting. And whenever people ask, why can't I use it in the frontline setting? If it worked, people would use it first. They would use it first. They would use it before surgery. They would use it right after surgery. They would use it in the first line setting. But because it doesn't work that well, we use it in the subsequent line setting. So after you've used your chemotherapy, then our second line setting tends to be immunotherapy. And you'll see some roles for it. I'll just go over because the most common two that we see and that are approved in sarcomas, soft tissue sarcoma specifically, it's Keytruda. So you might have heard of it. It's called pembrolizumab, but you see the commercials as Keytruda. And then Opdivo is the other one, which is also known as nivolumab. The reason why there's a Y is because I think Dr. Kelly alluded to this, but they're all monoclonal antibodies. So the monoclonal antibodies are kind of shaped like a Y. So that's why they form, that's why we like to see the little Y, because that's what an antibody actually looks like. So those are the immunotherapy options we typically have. And then just to go over a little bit about the efficacy, I think this was actually, they're published in, this was in one of our big cancer conferences this year, but they were taking a meta-analysis looking at a whole bunch of different studies with soft tissue sarcomas and using what we call PD-1, PD-L1 inhibitors. So that's what the Opdivos, the Keytrudas, these types of immunotherapies we call as immune checkpoint inhibitors. They were looking at 9 different studies and they put them all together. Now, 350 patients, I remember my sarcoma, the person who trained me in sarcoma, he told me that anything, if you look at a breast cancer study, you have 10,000 patients. You look at a lung cancer study, you have 5,000 patients. You look at a sarcoma study, 100 is a lot, okay? So 350 is a huge study in sarcoma, right? So for 350 patients, they had an objective response rate of 8%. Now, 8%, if you want to compare it to other types of lung cancer with high PD-L1 expression, 60% response rate, right? So you get a huge drop in what we would expect normally 50%, 40% response rates. In sarcoma, we see about 8%, okay? All right, the third type of treatment that I can offer you as a medical oncologist is something called targeted therapy. So what is targeted therapy? Well, it actually is a little confusing because I just listed some different versions of them. The most common thing is we try to find out what kind of mutation is driving your cancer. If we can identify the oncogene or the mutation that drove your cancer, and we happen to have a drug that targets that particular mutation, then we can actually stop the cancer cell from dividing. Now, that's not always possible, but if it is, that's what we call blocking a molecular target. The other one, which is also common, and we also use it pretty frequently in sarcomas, is something that can stop blood vessels from forming. So sarcomas, soft tissue sarcomas especially, make blood vessels, and they use that blood vessel supply to grow. So we can actually block the ability of the cancer to make more blood vessels and then therefore kill off the cancer, okay? And then the third one is sometimes you have different hormones that can feed the cancer. So we can block hormones, and those are other kinds of targeted therapies. The only difference with most targeted therapies, they tend to be oral. So most of these are by mouth, which makes a lot of patients prefer them over chemotherapy. So where does it fall in this huge table? So I circled a few of them for you. There's actually another one at the bottom right. But the one that everyone loves to talk about in sarcomas, and it's the reason why we run mutation testing on every single patient that comes to me with soft tissue sarcoma, is a gene fusion called NTRK. It's called NTRK. Now, NTRK is so popular because they ended up finding 2 drugs for it now, larotrectinib and trectinib. If you can get this mutation, and you should ask every doctor to run it for you just in case, but to find it is less than 1% of soft tissue sarcomas. But if you can find it, the larotrectinib response rates, I just showed you 8% for immunotherapy. They're probably closer to 80% if you get larotrectinib on you. So if you definitely don't want to miss it, but unfortunately we check it on every single patient and it's less than 1%. Pazopanib is what I was telling you about, is a way to block, different ways to block the ability to form blood vessels. There's actually another one over there called cabozantinib in the bottom right. I think it's blocked off, but very similar to pazopanib. I will say that this happens a lot. You'll have patients come to see you and they say, I can't do any more surgery. I can't do any more radiation. I'm not doing that red chemo. So then what do I offer them? The same thing every time, pazopanib. It's a pill, relatively well tolerated, response rates in the 10%. You take it at home, you take it on a cruise, you can do whatever you want with your life, but you can still have this medication and come see me every month. So larotrectinib, this is the pill I was telling you, it's a magic bullet drug, but unfortunately it's only available for about less than 1% of all soft tissue sarcomas. Pazopanib is the other pill you might hear a lot about. So that's the one that it's a pill. It blocks the ability to form blood vessels for the cancer. And it's used in the second line plus setting for soft tissue sarcomas. We can give it to you. You can travel with it. I think it's a good option for people who want to maintain quality of life, but knowing that this isn't a curative treatment option. So in conclusion, the medical oncologist, he dedicated his life to sarcoma. His name's Christian Meyer. He kind of taught me everything about sarcoma, and I kind of followed him around for a little bit. And then every time I have a sarcoma patient, I just call him. So he sent me this slide for, this was actually, he presented it at the 2024 ASCO, but his two main sticking points. So when you talk to a sarcoma patient, you should try to balance their hope with a plan. So especially because sometimes people come in with the hope for cure, but we know it might not be realistic. So, your plan has to match up with whatever their hopes are. And if their hopes are a little bit unrealistic, sometimes you have to match what the plan is with what and maybe temper down their hopes a little bit. The other thing is this thing called optimism bias. And I mean, you can refer to it both as the patient and the provider, but this is kind of the expectation. Sometimes this could be, if you want to say it's a patient, the expectation sometimes is that, you tell them this is what's going to happen. You're going to do radiation, then you're going to do surgery, and then you're going to be done with all treatment. That's kind of what the expectation is, but you can see what the reality is over here on the right. And oftentimes you run into a lot of different issues. You're hospitalized for a number of things. You have complication after complication. You break, I'm sure Dr. Kelly knows this, you do limb salvage and then you fall, break your hip, then break your leg, then do a knee amputation. So it just goes on and on. So I think part of it was the patient has this expectation, but actually and I'll finish, this is the last thought, is that they talked about this a lot at the cancer conference this year, is that we actually have a medical, as a medical oncologist, we actually all have optimism bias. So we're kind of afraid to think that our patients are going to fail. So it was actually something that was brought up quite a bit. So we actually kind of think about the best outcome for our patients. And sometimes we always think of it as the best case scenario. Okay, this is what's going to happen. This is how it's going to work. And then so we kind of actually have our own expectation that everything's going to work perfectly. And sometimes that expectation isn't reality, but that's what we're conveying to our patients. So, I think there's some kind of balance between what you can actually tell the patient and say, okay, we're trying to be very optimistic, but the reality can be something like this, right? So just to be careful for all providers and for the patients too, to have too much optimism and then balance it out with what's going to actually happen in reality. Okay. That's it.
Thank you, Dr. Wu. And, I think he's being very humble when he said medical oncologists are the least of importance. So I want to bring up Wendy Sweet. And, whether you're affected by sarcoma or not, you will know somebody who's been affected by cancer itself, right? You've already heard the statistics from Dean Shoemaker earlier at the outset. And, for me, my father had cancer and it was a really tough, you hear different words, journeys and whatnot, but it not only affects the patient, right? It affects the family, the partners, the friends. So I really appreciate everybody here taking time to be present and online. But I want to bring up Wendy Sweet, and I had a chance to meet her because she interviewed me for a story about cancer with I have a role at the American Cancer Society who's also here represented, but wow, to just listen to her story too of what she's gone through. And there are really, we all have bad days, but I mean, just to be able to come back and do something with the platform. She's a journalist, she's a producer, she does so many things that I don't understand, but she's an advocate and she's taken tragedy and turned it into a positive outlook, trying to do something to help others. And I don't know if anybody where everyone's like that, to be honest. Sometimes when you get bad news or whatnot, or tragedies happen, you can kind of go into your own shell and just not care about others and just say, you know what, it happens, I'm not going to help others. But to be able to, when you listen to her story and to be able to to do what she's done, gone through all the challenges and continue to perpetuate positivity and try to do something to help others in the community is just, it really just an essence of, my wife would always say the essence of aloha. What makes Hawaii really so special. So I didn't go too much into the treatment when I gave my overview, because I think the speakers here are really the stars of the show. So, but without further ado, Wendy Sweet, please come up. Thank you.
Great. Thank you very much, Dr. Marita, and to the researchers and healthcare heroes who are here at the UH Cancer Center bringing us hope. I often introduce myself as a writer and producer, but that's not why I'm here. I used to introduce myself as a wife and mother, and I'm neither of those anymore, but that's why I'm here. To share a few things I've learned from 2 one-year cancer journeys, 1 month apart. In those 2 years, September 2018 to September 2020, I went to appointments at Straub, St. Francis, Holly-Momi, Kaiser Permanente, and Queens Medical Centers, Adventist Health Castle, and MD Anderson Cancer Center. Grateful for health insurance from Kaiser, HMSA, UHA, United Healthcare, and MedQuest. Navigating from chemotherapy to oral chemo pills and surgery to radiation. With twice as many opportunities, I feel like I learned twice as much, fast and furious. I had to. When my husband Howard was diagnosed with colon cancer, stage 4, they told us there was no cancer in his colon. It was in his bones. So I asked a lot of questions, like, why did they only recommend chemo and not surgery or radiation? And what about a bone marrow transplant? Yeah, no, he didn't have bone cancer. He had colon cancer in his bones and with no target for radiation or surgery. And that's when I realized that I didn't know what I didn't know. When our 27-year-old son, Brian, was diagnosed with a metastatic proximal soft tissue sarcoma, stage 4, I asked a lot smarter questions. But they said it was a rare cancer with no known cause and no known cure, and almost no clinical trials or ongoing research. And for those of you who noticed that I didn't actually name the sarcoma, I did that on purpose, and I did that from the beginning. When Howard learned that he had cancer, he didn't want to talk about it. He didn't want folks asking him how he was doing or telling him he looked good. Howard was a businessman, and he chose not to tell anyone at work. He wouldn't let me talk to his only brother. He was a very private person, and for months he did great and he looked good. After 4 chemo sessions, doctors said he was cancer-free. And I wish that was the end of my story. When Brian was told he had cancer, he told everyone on social media. He embraced the love that he received. Brian was an athlete. He played 3 sports at Punahou School, won state championships in each one, and played football for Utah State and the Detroit Lions. So he faced cancer like it was his next opponent. He built himself a team. He picked up the phone and called former coaches, teammates, and even trainers. With dozens of well-wishers and cancer survivors, some who had survived sarcoma. A neighbor told me She had been living for 20 years at the time and longer now after successful sarcoma surgery at MD Anderson Cancer Center. A colleague said her husband is thriving today, many years after surgery, by Peter Pisters, a young sarcoma surgeon then who is president of MD Anderson today. And a few months earlier, one of Brian's classmates' mom had gone to the MD Anderson Sarcoma Clinic, and we decided to follow her path there. But we had a big problem. We may not have had the best insurance. Now, I'm no expert in health insurance or anything else, but I have learned a thing or two, and perhaps some of that can help some of you. Brian received his diagnosis from the Mayo Clinic via Kaiser Moanalua, and we loved his oncologist there. But we decided to leave Kaiser for a better chance to get to a major cancer center on the continent. We made the switch to HMSA with a PPO plan, and Brian also qualified for MedQuest. And that's something I would like everyone here to know about. If you have low income or no income, not working because of your illness, you may benefit by switching to Quest or adding it to your current plan. Double coverage. It can be twice as nice. And before you ask, yes, Quest is a state program. It does not cover medical expenses outside of Hawaii, but it can cover travel costs for qualified medical reasons for the patient and in some cases, the caregiver as well. And that's an example of something that's good to know that I hadn't known. Another example, people who travel to Honolulu for cancer care from neighbor islands and Pacific Islands can apply to stay at the American Cancer Society's Hope Lodge for free. That's something I didn't know then, but you do now. And here's something else that I didn't know, because why would I? A lot of people change insurance plans during open enrollment at the end of the year, and most plans start in January. So if you're going to switch or add health insurance like we did, enroll in your new plan and schedule appointments as soon as possible. I didn't know that then, and I didn't do that. So Brian didn't go to Houston in January. He did get appointments in February, and we came home in March 2020 as COVID lockdowns began. During my Too Fast, Too Furious 2-year cancer journey, I learned not to expect to learn everything everywhere all at once. Doctors won't tell you everything, even if you ask, and for sure not all at once. But here are a few suggestions that might help you get the best care from your doctor. Write down a few questions and bring them with you to every appointment. Ask about nutrition. Should you fast for 24 hours before chemo? Would your doctor recommend IV fluids following treatments, if it would even help? We did, and it did. And always ask, what other questions should we be asking? That's when you can learn the most. Also consider this. Write a 1-page essay introducing yourself. Are you a wife and mother, a businessman who loves sailing, an otherwise healthy young adult who loves fishing, eats a clean diet, and works out daily? Add a timeline of your symptoms, diagnosis, and treatments. Mention things that are important to you beyond your medical record, like staying in Hawaii for care, participating in a clinical trial, or finding a group to connect with. Then upload your essay to MyChart and give your doctor a copy with a photo of you and maybe your caregiver. And one more thing, and I just realized that I didn't change my photos. I think I can change it. Hey, buddy. That's a photo of you and your caregiver. And one more thing, the internet is a wonderful place where the wild things are. You can learn as much as you ever need to know about any type of cancer if researchers have studied it and published their findings. For rare cancers, and diseases that affect young adults, not so much. So to all you cancer researchers who are bringing us hope, I hope that you get all the funding you need and you'll dedicate some of your research love to diseases that affect young adults and rare cancers in your quest for a cure.
Thank you so much. Such a powerful testimony, you know, an advocate to help others. A lot of words of wisdom. I'd like to next call up Mr. Bernard Kikua, who lives out in the west side and really is epitome of Hawaii, where we see so many unique ethnic groups, right? This is not a type of ethnic sort of population that we see all over in the country, but this is what makes Hawaii so different, right? We have these ethnic groups and we have community and we have neighborhoods, and we have an opportunity that he took the time to bring his family all the way here from the west side, and really want to appreciate him giving us an opportunity to listen to his journey. I had a chance to be involved in his care, but he can tell you all the different challenges that he had to go through. And you know, for many of you out there who may or may not be wondering if something is going wrong, or you have a lump, or you have something that you know you're concerned about, you know, he will tell you that you know seeking care can make a difference. So without further ado, Mr. Kikua, thank you for coming up.
Hello, everybody. My name is Brennan Kikua. Thank you guys for letting me share my story today. I'd like to introduce my family, my big support system. That's my other half right there. That's my oldest daughter. My oldest son, Chevis, Charbonnet, Shine, Shane, and my little one is out there, China. Anyway, thank you guys. Oh. Anyway, my story started maybe about a year and a half ago. We just was going. It's about Christmas time. We was gonna go shopping at Pro Ridge, and I just felt an odd pain in my stomach. Something that I don't know was real minor. Never seemed like anything major or nothing, but it was just different. So my wife told me that maybe we should go check Palimomi and just go see what's going on. So excuse me. We decided to go. I went there, anxiety out, kind of wondering what's going on. But definitely at that time, I was about 275, 280 pounds. Definitely eating unhealthy. Started trying to work out and stuff before I even found out about this. Trying to eat a little bit better. Anyway, towards that end of my visit, took some hours, seemed like it took forever. When they did come in and tell me, my family was actually shopping at Pro Ridge, I think, waiting for me. The doctors came back and actually told me that they found a mass. They never told me they found a pebble. Said they found a mass. So that kind of just kind of put me in awe. Telling myself, oh man, you know, why me and all this stuff, wondering what's going on. Anyway, they never told me it was cancer or nothing, but they just told me it was a mass at the time. Thinking back, you know, I kind of felt that something was gonna go bad with my health because of the way I was living. So that was what had happened at that time. They told me I had a mass and I had to go look further into whatever was going on, see some doctors. So I think before I seen a doc, I went to see another doctor. at Queens. I forget his name. But anyway, he told me that this is something that they don't want too much studies on. It's kind of even more scary for me. They said it's kind of I don't know what they use. It's very small chance to get something like this, I guess, percentage wise. Sarcomas is not common. So anyway, um, during that time, I went. This doctor referred me. He said that no, I would recommend Dr. Morita. So I kind of asked him during that time. I was thankful to be a little bit strong with the Lord. Thankful for having him in my life and just being back with the Lord. So that kept me strong in my this process that I was going through. Anyway, I found out that Dr. Tu is a man of faith. I believe that God just has on purpose for all of us. I never think it was gonna be this cancer, but for me. Anyway, talk with Doc and they told me that they need to remove this thing because this mass was pretty large. I want to say maybe like this size. It was sitting on the left side of my stomach, close to my aorta. So they said it was kind of dangerous for me to be staying with that thing in my body. And he said, we gotta see what we can do to do a biopsy. I think we did to see how aggressive this thing was. Thank you, Jesus, that it wasn't as aggressive as they was thinking. So, I was able to prolong them a little bit. So I was able to change my diet. Started drinking these shakes daily. My life, it's up there. Anyway, this is my family stuff. I started to drink these shakes daily. I hardly could eat any food because any type of food that I would take in, it would cause me to have this stomach pains. That I knew that was because of that. So I just continued for try to eat healthy and actually even tried for doing a vegetarian diet. I couldn't do. So that definitely wasn't the best thing for me. But changing my diet was definitely good for me. Exercising, working out with my son, my kids, going to the beach. That really kept me positive and hopeful, and saying that, you know what, this thing is already part of me right now. I just need to get this out. So I was scared, but I had plenty of hope and plenty of faith in what was to come. Definitely because of the Lord and my family, the biggest support system that I get. Positive people like Doc telling me that, stay cool. We got this, and really, really, only the Lord knows what is God for us. So I just have to have hope and just keep the faith. These are the shakes that I've been doing. I swear I must have drank them for like 40 days straight. That tuna sandwiches, whatever, regular turkey, ham sandwiches, steak, chicken, shrimp. Just not McDonald's and stuff, all the fast foods. This just went out of kind. So after they did my biopsy, like I said, they found wasn't as aggressive, so gave me some time for lose some weight, eat healthier, get ready for my surgery. That I've never had surgery in my life, man. This is kind of interesting for me. I was scared of needles and even with all these tattoos and stuff. It was just interesting, but the support system that I had was one of the biggest things for this thing. Without one support system, I can imagine that things would be lonely because even with my family, my support system, like I said, was lonely at times because I get cancer. I think I'm gonna die if this is the last time I'm gonna be able to be with my kids, my family, talk with you guys. So I'm thankful today that I can do this and share this with you guys. Whether it helps somebody or not, I don't know. I hope so. It's definitely helping me. So again, this is I believe right after maybe I did my surgery already. I mean, going towards recovery. So today, I'm still in recovery. After we did my surgery and stuff, came home. Sure, must have took at least 2 weeks of having a hard time getting out of bed, being fed. Thank you, Jesus, and I could use the bathroom on my own, bathe myself. But my family was there all the way helping me. I'm just thankful for that. I believe my journey wasn't as hard as some other people, and I'm just thankful for that. You know, the sarcoma thing, it's no joke. Before my surgery too, they wanted to put on stent, some kind of thing for feed me chemo, but I refused that because from what I was told that chemo is gonna make me weak and wasn't known to work. So I just took it on faith and hope that doc said, you know, we'll cut this thing out. A big surgery and a big movement for me. But we can do this, and just thankful that today, here in recovery, cancer free, still with one support system that love me and I love them. I just hope that if anybody, you know, feels lonely, find that support, reach out, just touch base with people, because God just definitely never intended us for doing this thing alone. And alone is definitely not the way. So, I don't know. Thank you guys. I wish I could share more. So thank you. The guy, doc. Thank you, doc. Thank you, guys.
Thank you, Mr. Kiko, for your bravery. I know that wasn't easy, but you did an amazing job. Your surgery wasn't as easy as you make it sound, but anyway, thank you. But I really want to transition now into another survivor here, Carolyn Huff. She is here with her family, very famous family, by the way. But she grew up in, you know, on the west side and in the plantation, family pineapple plantation, and has a background where she got her MPH here at the University of Hawaii, and she ended up going into health education and really helping folks understand, you know, all the different challenges that she had, and even to work with the Department of Health. And I will tell you, when I first got to meet her, she asked a lot of questions. You know, what Wendy Sweet said is asking a lot of questions. I mean, that's what you have to do, because this is your body. This is, you have cancer, you need to understand. If someone doesn't explain it to you, maybe that person may not be the right, you know, advocate. And so, you know, I think she's gone through quite a bit. I'll let her talk to you and discuss all the different challenges that she's had, but really appreciate her bravery and her willingness to speak and share the challenges. And, you know, some days I know, I'm sure, are good, some days not so good, but we really appreciate her sharing her story about her GI stromal tumor. Mr. Kikua had a liposarcoma that I had shown. You have another patient who had that, and that was treated with surgery. But sometimes, as Dr. Wu had eloquently said, sometimes sarcomas are treated with different types of medications, targeted therapy. So I'll have her, without further ado, come up and share her perspective. So thank you so much.
Good evening, everyone. Thank you for being here. I'd like to introduce my family too. My husband, Daryl, and Nicholas, and my daughter Alexis is online in Seattle. Love you, Lex. Okay, so when Dr. Marita asked me to speak at this event, I had to think about it because it's still very fresh and I'm not out of the woods yet. I was diagnosed with sarcoma just last year and breast cancer in 2004. My sarcoma is called gastrointestinal stromal tumor, otherwise known as GIST, like what they were talking about earlier. Last March, with severe abdominal pain, I went to the Queens West ER. I thought I had appendicitis because the pain was on my right side. It wasn't appendicitis. The ER doctor told us the CT scan showed a large mass on the left side of my abdomen. He said it looked like cancer. It was over 4.5 inches long. We were stunned. After my discharge, the doctor called me to tell me I had GIST. I'd never heard of it. I asked him if it was cancer, and he said yes. He said the biopsy indicated it was slow growing. He said I would need medication to shrink the tumor. I called around to find an oncologist and was told it would be about a month before I could see one. My husband, Daryl, expressed his frustration about the delay to a doctor he knew, and thank God that doctor contacted Dr. Shane Morita directly, and he was on the phone with us that night. We met with him the following week. Dr. Morita had ordered a tumor profile, and it said the GIST had a specific mutation, KIT exon 11. All of these acronyms and medical terms I'd never heard were hard to absorb. I finally got an appointment with medical oncologist Dr. Nicholas Villanueva the week after I saw Dr. Morita. A week after that, I woke up at midnight with terrible pain in my abdomen and chest. I thought I was having a heart attack. I was in so much pain, I couldn't speak. So I lifted up my arm and dropped it on Daryl to wake him up. We headed to the ER at Queens Punch Bowl. Daryl texted Dr. Morita to let him know we were going to ER. Dr. Morita arrived in the ER in scrubs and wearing his surgical glasses, ready to do emergency surgery. Later, he told us that if he did surgery that night, he would have had to take out my entire stomach. The CT scan showed the tumor had grown and bled. When it became clear that I was stable, I was discharged. I was due for a PET scan a few days later that would tell us more about the cancer and help plan for surgery. The day after the PET scan, Dr. Morita called to tell me he was canceling the surgery and I needed to start medication immediately. We met with both doctors that day to see the scan. Here's the scan. That big, bright spot is the main tumor. And there are several smaller spots showing the cancer had spread. The doctors agreed that I was stage 4 and that I couldn't have surgery yet. I wondered if I would survive the rest of the year. I took the first daily dose of imatinib mesylate that afternoon. It wasn't long before I noticed the pain seemed to be going away. Daryl said he was glad to hear that, but later said he thought the improvement was just in my head. So irritating. He thought that. After about a month on the medicine, I had another PET scan. When Daryl got home, I logged on to my chart, even though Daryl said we should wait to be with a doctor when we learn the results. I didn't listen to him. I wanted to know. We read the results together. Complete response to therapy. There is no evidence of active GIST tumor in the left upper abdomen or in the multiple peritoneal implants. There are no new hypermetabolic abnormalities. We were blown away. But then we thought, is this for real? We finally saw the scan 3 days later with Dr. Villanueva. The picture was even more amazing than the written report. The bright lights were all gone. You don't see the bright lights up there anymore. I told Dr. Villanueva, either this is a miracle or the machine is broken. Because the medication was working well, the doctors agreed we should give it more time to shrink the tumor before surgery. Over the next 7 months, scans showed the tumor still inactive and slowly shrinking. The longer I was on the medication, I had more side effects. My legs got crampy and weak. I was tired all the time and had to take naps. My skin got pale and more sensitive to sunlight and temperature. I thought to myself, is this how I'm going to have to live the rest of my life? I was desperate to learn more about GIST and meet other GIST patients. I looked locally and didn't have any luck. So I defied my doctor's orders about doing research on the internet. I found a support organization for GIST patients called the Life Raft Group. It had a lot of helpful information. By December, it was clear that the tumor wasn't shrinking as fast. Dr. Morita scheduled surgery for the end of January. On January 30, Dr. Morita removed the tumor and the margins around it and cut other nodules that he could see. He only removed a very small portion of my stomach. Because there was still a chance there's still cancer in my body, the doctors say I will continue to take the imatinib indefinitely. 3 months after surgery, my PET scan still showed no sign of active cancer. I feel better. I started walking again for exercise with trekking poles to help with the hills of Makakilo. It was such a freeing feeling again to be able to walk, to exercise. Because I'll be on imatinib for a long time, I am with Dr. Melvin Palalai, who has years of experience with sarcoma and is helping me with the side effects. Oh, did I go backwards? Sorry. Did I show that one? Okay, sorry. Okay, so I'm sorry. My breast cancer experience was very different. I discovered a lump in September of 2004 when I was 37 years old. I turned to a network of friends who had experienced breast cancer and professionals in oncology who I knew. Shortly, I had an appointment with a breast surgeon. I had an outpatient lumpectomy and was diagnosed at stage 1. It was much easier back then to get appointments with medical oncologists. We interviewed 3 oncologists who recommended various treatment plans. The path was so clear from the beginning: lumpectomy, chemo, radiation, and tamoxifen, and a 90% or more chance of cure. There was a clear light at the end of the tunnel that helped me cope with the severe side effects of treatment. There were many breast cancer survivors willing to support new patients and a vast support system in Hawaii and nationally. Compared to breast cancer, it is easy for a sarcoma patient to feel alone. In this next battle for my life, I am so grateful that I have a great team around me. First of all, I'd like to thank God and the Virgin Mary who heard my rosary prayers and comforted me. I am so grateful to Dr. Shane Morita. Thank you, doctor. He took our urgent calls at all hours. So I want to also thank his family and his staff, Kelsey, Trisha, Judy. You folks are so awesome. Dr. Nicholas Villanueva, Dr. Melvin Palalai, Dr. Christopher Aoki, Dr. Megan Sakamoto-chan, my breast cancer doctors, Dr. Laura Hawk and Dr. Clayton Chung, who both have passed, and Dr. Scott Moon. The skilled and caring nurses, doctors, technicians, and staff of Queens Medical Center and Queens Medical Center West Oahu. My extended family and friends, I was touched by your kind words, prayers, and gestures of compassion. I'd even like to thank my insurance companies, HMSA for my breast cancer and UHA for my sarcoma, because I cost them a lot of money. Sorry, thank you. Sorry, thank you. Thank you, seriously, thank you. My husband, Daryl, and his employer, Hawaii News Now, who let him feel free to be a supportive husband. My son, Nicholas, who is here, and my daughter, Alexis, who is online in Seattle. Thank you for being brave as you watched me go through this twice. You are the reason I'm fighting this with all that I've got. And thank you for listening to my story.
Thank you so much, Ms. Hope. If you need to take, step away and take a few minutes, please feel free. Thank you for all of you again who joining online. We like to call all the panelists up and again, remind you that this is really, we appreciate UH Cancer Center serving as our hub, and you can hear all the different partners that we have with insurance companies, foundations, and hospital systems. Thank you so much. Please, if you don't mind, all the folks, the speakers come up here, take a seat. We're gonna have some questions. I know some have online and in person here. If you have any questions, please feel free. If you're in person, come to the mic. If you're a little too shy like me, please give a index card to Michelle and we'll get it to the right person. This is an opportunity to ask any questions you want and we'll do our best to answer it. If we don't know, we'll find the answer, okay? But thank you so much for, again, coming and being here. Michelle, who's running around here as our coordinator and really been the one that's done so much for this event. So I really want to give her a shout out. She has the sign up sheet. So if you're interested in participating, creating any, we're trying to create a Hawaii Sarcoma Alliance. We will create it, but it's just a matter of we're doing a needs assessment now, and we will do our best to meet here on campus periodically. If anybody has any questions, we can certainly direct them to any of the panelists. We also have some folks here from UH Foundation who do a wonderful job in bringing awareness to all the different programs that the University of Hawaii Cancer Center is doing and all the outreach in community. And, really want to show and showcase that the University of Hawaii Cancer Center is not only a research facility, really it's a public institution, it's NCI funded. And it's really an opportunity for the public to see what it does. And it is, you know, having these types of programs that provide community education and outreach. If there's anybody have any questions, I'm happy to take. Thank you so much for volunteering. Go ahead.
Thank you. Hi, my name is Linda Asato, and I'm a Patient Advocacy Council member. My question is, if you have had cancer previously, like I've had breast cancer, does that put me at higher risk of sarcoma?
You know, I think that's a great question. I think, you know, we know, I think Dr. Wu had mentioned some risk factors. For example, there's certain genetic conditions such as leishmania, or there's even neurofibromatosis, but even certain types of radiation substances. But Evan, you want to talk about, you take care of a lot of patients, and you know, I think there's always a concern of developing a second malignancy. We see that in our survivors. So have you take that, Dr. Wu? Oh, yeah. Brenda, go ahead.
So I just wanted to underscore something in response to that question. Because of the small numbers, you know, it's difficult for us to really look at subsequent risk of another cancer in a rare tumor like sarcomas. But, you know, we do know that in general, that certain types of cancer treatment may put a person at risk for a subsequent cancer. So for example, if you have radiation to certain parts of your body to treat a cancer, that can increase the risk of a subsequent cancer of another type or the same type of cancer. So unfortunately, I don't have, you know, the statistics in terms of the rates of a second primary after falling to sarcoma. But in general, you know, just in terms of what we know from our experience with other more common types of cancer.
All right, thank you. I'm gonna go, this one is right in Dr. Wu's wheelhouse. How useful is whole genome sequencing in predicting cancer risk? Some concierge medical practices are offering this test.
Oh, yeah. So I'll have to separate that out into two different types of genes. So something that I think confuses a lot of people, including a lot of even some people who are in the science world. So we have a concept in cancer called germline mutations, and then we also have somatic mutations. So the way I explain it to patients is germline means you inherited from mom and dad, and then you have somatic mutations, which you picked up those mutations over the course of your 45 years of life. 38 years of life. Wow, you're young. Okay, so those are two different concepts that we have to understand. So when we talk about these different kinds of mechanisms for saying, how do you predict your cancer? Well, you actually have two different components, because you have the component that you inherited from mom and dad. And so that would be something like a germline BRCA mutation that you might have heard about for breast cancer. Well, that's something that's an inherited risk that you can detect through these different kinds of germline risk assays. But then the second part to it is, a lot of people have mutations that cause cancer throughout life. Is that going? Oh. That are not related to your inherited risk. So you can have no family history, mom, dad, nobody else, and then all of a sudden you develop something like a soft tissue sarcoma. So we presume some of that has to do with these somatic mutations. Somatic mutations we tend to think about as more environmental. And you know, one of the questions everybody always asks is, you know, how did I get the cancer? Was it because I drank too much? I used to have a patient who used to think it was because I drank too much Tab, that soda that doesn't exist anymore. And they were convinced on that. But so, and I always tell them, you know, we actually have no idea. That's what Dr. Hernandez, epidemiology studies do that. But, you know, to answer your question, there's not really, the whole genome sequencing is probably what they're referring to as germline mutation testing. You know, they have these vendors called Myriad and things that do that. Those are definitely an option. they're a very expensive option. And then even when they give you that risk, you don't know what to do with it. So it's something that we have in Hawaii, actually quite a few genetic counselors. And then even the University of Hawaii actually offers a genetic counseling service. So it's something that if you really want to learn more about it, I would actually recommend seeing a genetic counselor and then seeing if you're at risk. If you're at risk, then you can do these types of germline testing, knowing that germline testing is not the most comprehensive because you have all these other kinds of mutations that cause cancer that you don't inherit.
Okay. All right, thank you. I have another one here. Let's see, after removal and an intra-abdominal cyst, how long before you consider the patient is in remission or is cured? It's very hard for me to use the term remission cure. Sometimes I feel that, cancers can come back even 10 years later. I'll tell you, one of the ones that I take care of quite a bit of is melanoma. But, we typically use 5 years. I think that's a good anchor point. And also just you're looking at the pace of disease and different patient stages and whatnot. So I think it's very individualized, but I typically see 5 years as a good marker. But again, if you talk about just your run-of-the-mill like liposarcoma, for example, sometimes they can actually recur even later to even 10 years out, but it varies. But for GIST, I think those typically declare itself. So I typically use 5 years. I don't know, Dr. Wu, you might have a different, answer.
Yes.
Usually what I advise people on is if it's a very well-known tumor like breast cancer, lung cancer, and we have a pretty good idea that after 5 years, you're most likely to be cured, then usually I'll stop surveillance around 5 years. What I do for sarcomas is actually different because what I tell them is sarcomas they're not common, they're rare. We don't understand them as well. So I actually follow all sarcoma patients for 10 years because of that. So.
Great question. I think it's like I said, it's very individualized and it really depends. Some GI stromal tumors have really aggressive features, some not as much. And you have to understand too, there is a cost of this too, right? Getting scans every so often, it causes a lot of anxiety. It's expensive, and it also gives you radiation exposure, especially if using CT scans. And for those of you who have undergone a PET scan too, that's a lot of radiation too. But I have actually Dr. Paulai, he's one of our go-to medical oncologists here. And, Dr. Paulai, you're welcome to answer that question as well. What are your thoughts regarding GI stromal tumors and whatnot? Mike right there for you regarding how you follow them and cure, because I think it's very individualized. I use 5 years, but it is individualized. Yeah.
So I've been around for a long time. And I only say that in context because when I returned home to Hawaii and started practicing at Hawaii Medical Center West, there was a patient who had GI stromal tumor. And this would have been in like 2000. And this tumor had, taken over somebody's abdominal cavity, a woman. And we really didn't have a lot of options at that time. And we reached out to all these major tertiary centers, including Memorial Sloan Kettering in New York, all these leading places for sarcoma. And the best we could come up with was chemotherapy. And we tried hard and you know, like Dr. Wu was saying, there's only some limited effectiveness for at least these types of agents. And then somebody discovered that, you know, there was a mutation that could be targeted that really changed the whole game, you know, and so it's become clear that the role of these targeted treatments play a central role in GI stromal tumors, and the role of adjuvant therapy has become important. So that means that when the tumor is removed, there's additional treatment that's offered to patients so that we can minimize the risk of a recurrence and to enhance survival. So, and the duration kind of varies from study to study, but a lot of us will continue the targeted treatments for several years after the complete tumor removal. So like Dr. Wu said, you know, it's quite variable. A lot of us use these guidelines that are established by research centers like and we try to adhere to that. Yeah, I think 5 to 10 years is probably appropriate, but we have latitude, you know, to go beyond some of the mandates that they're not mandates, but guidelines from evidence-based organizations like the National Comprehensive Cancer Network. The scary thing about, you know, some of these other tumors is that there are late recurrences, you know, recurrences that occur after 5 years. And so that includes melanoma, unfortunately, and that includes breast cancer, at least the hormone receptor positive types. And so, yeah, it really is. I think we're trying to improve our primary care follow-ups as well, because unfortunately in Hawaii, we just don't have enough medical oncologists to do all that surveillance. So I think that is going to be important as well, is working with our primary care providers in being better stewards of, you know, disease recurrence, and also screeners for disease as well. So.
Thank you, Dr. Paulai. Like I said, he's has a lot of wisdom, and he's been around a long time, and he's a great colleague. I work with him at Queens quite a bit. We have someone asking about clinical trials, and you know, we've had various studies involving sarcoma and, you know, novel treatments. Can you maybe allude to, I would say, why don't maybe we go, Dr. Kelly, about clinical trials and sarcoma? I know we've had some clinical trials before, and I will ask if any of the patients have been involved in clinical trials, but maybe you want to comment on clinical trials. I know we're working on some different studies.
Yeah, so I think when it comes to clinical trials in sarcoma, the hard part is getting enough patients to actually enroll in these. And so most of them are collaborative through multiple institutions. So we've been making some efforts to get that started here with a few looking at dedifferentiated liposarcoma and a few others. But one of the main things we're also looking at is trying to work with some other institutions. There's the Sarcoma Advanced Research Consortium and a few others that give opportunities for us to participate in national level research. So it's something we're just really starting to get into right now, I think. And so hopefully, if we were to do this conference in a year or two, we might have some more results on where we're going with that. Thanks.
Thank you, Dr. Kelly. There's a question or a comment from the audience about they had a leiomyosarcoma, which is a smooth muscle variant of sarcoma removed from the bladder, and the patient is doing well. And talking about any type of studies, I do think we have interest and a critical mass to gather that data and work with Dr. Hernandez in the Hawaii Tumor Registry. But I think surveillance is really, you know, really important. We don't have any ongoing studies right now for that, but this is why funding and the resources are so important. And so institutions such as UH Cancer Center is really critical in building that, with Dr. Kelly here and all the other specialists, Dr. Wu, it's really important that we continue to collaborate. Dr. Paula, we again take a lot of sarcoma patients. But I would like to ask maybe Mr. Kikua, if what are your thoughts about clinical trials? Because we do know that in the UH Cancer Center is really one of the centers across the nation that's leading that, because we do have a really, again, it's a diverse population, right? Just because a medication works in someone who's Caucasian or Asian, doesn't mean it may work in Native Hawaiians. And so I think, your vantage point is extremely important, because sometimes we'll hear in the community that there's, some Native Hawaiians or some, Chinese, Koreans, whatever, there's a little bit of hesitancy, and that's not profiling. That's the actual fact. That's what we hear straight from our patients. Could you give us an idea of how do you view a clinical trials, a study? Is there something that you would be interested in if you needed, thankfully you didn't need chemotherapy, as you shared in your testimony, because sometimes sarcoma patients do need chemotherapy, as Dr. Wu had alluded to. But what are your thoughts?
Speaking to this. Hello, everybody. No, but that's not me. Basically, what I we take ibuprofen. Try this. Oh, this thing not working. Stop. Thing not working. Try this thing. That's it. You gotta wait till Ivan make the change or something. Say, man, I don't like you to test on me, really. So I know that we need more studies on this, and I hope that we can get them. So I definitely after going through this, yeah, I'll kind of pick up on it. Just because of how it is. More and for like you'll give me chemo for this mass that I get. We don't know. He definitely gets you sick. Just taking this radiation or whatever it is. And then come to find out we get worse instead of getting better. So I don't know, it's just scary for me.
Yeah. No, appreciate your honesty. I do know that, like, for example, Caroline Huss and her journey, she talked about imatinib, but that's all, that data was all based on clinical trials. And Dr. Paulai had mentioned about how before some of those GI stromal tumors were treated with chemotherapy, which, Dr. would mention is essentially poison, right? It's given in the vein, but for GI stromal tumors, now we treat it with a pill. It's called targeted therapy, and that really paradigm shift happened about 20 years ago, right? It made the cover of Time magazine. So really, I tell people just be your own advocate and don't give up hope. There are many people, I've been doing this for 15 years, that I swear to God, when I first meet them, it doesn't look good and they're alive. You'll be surprised. There are stories that I can tell you, but I can't because of privacy, that there are some folks in difficult situations and they are still around. And I've been doing this for 15 and a half years. So, there's studies that are important. There's a lot of information, as what was said by Wendy Feet on the internet, but you never know. You never know. Don't give up hope. The longer you live, the more studies that will come about, and the more, it may not be clinical trials for everyone, and that's being honest, and that's fine. There's some people who are willing to undergo clinical trials, and that's okay. So I think, the more we have the data out there that we have, and the more challenges, we can all band together and partner, and we'll come up with solution. I mean, we definitely are a lot better now than we were 5, 10, 15, 20, 25 years ago. So, but that was a great question. Oh, yep. Question, go ahead.
Caroline was at Cunha Village when they shut down the water system. She was a teenager when heptachlor hit. She played in the pineapple fields. The pineapples were covered with heptachlor. They played in the streams and the water was flowing down from the plantation fields. I don't know, Mr. Pico, whether you had some kind of exposure you think in your life. But I'm just wondering, and Dr. Hernandez, is our surveillance system equipped so that you can identify a particular place or a particular time where an exposure might have led to cancers that don't show up for 20 or 30 years? And are we equipped for that? Are we getting there? And if so, can you tell me so I can do a story about it?
Yeah. Yeah, Brenda, you do a lot of work in, but I think what you're alluding to is cancer clusters, but maybe you can comment on that.
Right, so we do get quite a lot of inquiries about suspected cancer clusters. So generally, the inquiries will be, someone who lives in a particular neighborhood, and they notice that not only their neighbor, their neighbor's neighbor, individuals that they've known for many years have developed cancer. And so they're, oftentimes not knowing, it may be the same type of cancer or different types of cancer. So oftentimes there would be concern about, is there a shared exposure in our neighborhood that's making us at risk for cancer? So we actually at the Hawaii Tumor Registry have worked with the Department of Health to actually investigate suspected cancer clusters, and including some years ago, a concern that Cunha was an area because of the history of use of pesticides, and that individuals and homes that are now established in Cunha could still have residual exposure to some of those pesticides that got into perhaps the ground and groundwater. So at that same time, some of you may know about this movie, Erin Brockovich. So they actually organized and came to Hawaii, and that intersected at the same time that we were doing this investigation with the Department of Health. And so we ended up doing an investigation where we actually looked at cancer cases that were occurring among this particular area of Cunha and compared it to other parts of this island, as well as statewide, in terms of looking at major cancers. So what we found was that there wasn't an increased risk in this particular neighborhood. However, when I say that, I just want to underscore that there's so many limitations in doing this type of analysis, because in a particular neighborhood, you may have people who live there for 1 year versus 20 years versus, so it's very much, very different in terms of exposure. If it is a shared neighborhood exposure, of course, there are differences in terms of occupation and other risk factors, lifestyle, smoking, other things. So it's very difficult to really pinpoint if a specific shared exposure in a neighborhood and a cancer cluster is tied to, subsequent cancer development. But, we do know that, there are, so it's difficult to, in answer to your question, it's difficult to prove. But we are very much, one of the roles that we play here in the state of Hawaii is to follow trends in cancer, to be able to answer these types of questions. So for example, one of the things that we're seeing in our state, as well as nationally, is an increase in early onset colorectal cancer. That's colorectal cancers that are occurring in younger adults. And that's being seen not only in Hawaii, the US, as well as other parts of the world. And so our data only recently has been showing this. And so there is research ongoing now and being initiated to really look in what is driving that. Is it dietary? Are there other shared environmental exposures? So, but it's a very complicated picture when you're really looking at risk of cancer, because oftentimes it's not just one thing. It's a multiple types of, risk factors that may be involved. And even if you have same people exposed to the same risk factor, you have innate susceptibility that some people may be more susceptible to an exposure than others for various reasons. So hopefully that answered some of it.
Thank you. Great. I wanted to go for this question about gamma knife therapy and sarcoma. I know, Dr. Kelly, you deal with, as an orthopedic oncologist, you again deal with multiple different disciplines. Any thoughts on gamma knife therapy for sarcoma?
Helps might answer it better, but as far as sarcoma, the mainstay has been using conventional radiation, and we've used newer techniques. Proton beam is another type, just different types of radiation. The gamma knife hasn't really been used outside of the skull in those areas for sarcomas that I've seen. The newer research we're looking at is also looking at like carbon ion beams, and so there's different types of radiation. And we think about the importance of gamma knife or carbon ion beam and all these. A lot of it has to do with the ability to target certain sizes in certain locations. And so each one has its own little kind of target area that works ideal for it. And so if you had the right lesion, there could be a role for gamma knife, but I think most of them are too large, and there's better treatment options that are available right now for it. So there certainly are advances in different types of radiation, but I'm not aware of the gamma knife being used in such large areas. These tumors are oftentimes much larger than we use a gamma knife for, which is very precise and small. So.
Thank you. Yeah, no.
Sorry. I just wanted to respond to what you said about heptachlor, because I lived through that experience. And I understand that our congressional member Patsy Mink's daughter was exposed through the milk. And a friend of mine worked at the health department, and he told me that he had to dump all the milk, or had Medigold and other milk producers in Hawaii dump their milk because the cows were consuming. And I just want to comment that what you're saying, I believe it, that it has a lot to do with the pesticides. Yeah, sorry, just wanted to.
No, thank you for this comment. This is meant, we have nothing to hide. We're transparent, and so this is dialogue. And again, we're gonna build this alliance, and we'll do our needs assessment. There's a question that came about research in Europe and Japan. I wish Dr. Yamuchi was here. He had to leave, but I know he has a lot of contacts in Japan. But I do know I collaborate with in fact I wrote a paper for someone who was putting together a sarcoma journal. He's at the City of Hope now, but there's typically national meetings and international meetings in Europe, and there's a lot of collaborations, and you find out with the internet that the world becomes a smaller place. And I know Dr. Kelly had mentioned earlier that because sarcomas are rare, we really need to collaborate and partner and use some of that information collectively, because I think what happens when you have a rare cancer, I think it's important to gather as much information as possible, because you don't want to make recommendations based on a very small sample size. So I think there's a lot of research I'm aware of in Europe. I'm not familiar with Japan, so that's something we can find out from Dr. Yamuchi.
Two survivors in family care. One thing I just kind of noticed that's similar of all your stories is no one here presented with a small bump on their hand, right? These were all large and progressed. And I'm curious if there's anything you think in your own experiences that may have helped us catch this sooner, or was this something that you noticed that maybe we should look for in our patients? It's rare that we get to ask these questions of our patients and say, was there anything?
Went to the doctor or the hospital. So I just see them. What was we just talking about? I just went blank. I'm so sorry.
Think of like us as sarcoma surgeons.
Yeah.
We're trying to look at how to spread the
Oh,
word.
CT scan. Yeah. So like I said, they never find this mass. Only with the CT scan. So if they would have given me a CT scan, maybe 5 years, 10 years previous, maybe they would have found this thing. But understand, doc said that thing is expensive. Gives a free and whatnot. So I don't know what that does, but I know if they would have did the CT scan, they would have found it. And from what I understand, because the mass was like this, I think I had to have take some time for grow. Most likely. Oh, just
And that's a great point. There's no great screening tool. You know, you talk about breast cancer, we use mammography, colorectal cancer that Dr. Hernandez mentioned, we use in colonoscopies. But for sarcoma, you know, as I mentioned earlier, it develops anywhere. It can be intra-abdominal. So you have some type of unusual pain that just doesn't get better. Please seek care. If you notice a lump or bump, I tell people greater than a golf ball that just keeps growing, please seek, you know, further care. It can be on the extremities, your arms, your legs. You know, I just took out one. Dr. Kelly and I actually took out one a couple weeks ago that was on the thigh, and it was the size of a volleyball, because then we collaborated because it was involving we had to take it off the bone. So there's a question about sarcoma clinical trials. I'm not aware of any one right now. Again, periodically we will have clinical trials for sarcoma. We collaborate with some of the national centers. I do know we did have some using immunotherapy. I know Dr. Wu had mentioned, and some of the chemotherapeutic agents, but definitely immunotherapy, which has become much more available for sarcoma now. I'm not aware of any clinical trials that the patients here went through. I asked Ms. Huff regarding her prior breast cancer treatment. She was not, but I tell you, clinical trials are important, but you can see that there is some apprehension sometimes, and that's fine, and it's okay to do that. But the clinical trials are really lay the groundwork for treatment. You know, the GI stromal tumor treatment drug that we use now, imatinib, that you're currently taking, that was from a clinical trial that, you know, launched over 20 years ago. So without those studies, we don't have enough data. Aaron, you had a comment? I didn't see in the back. Yeah, please, your clinical trials team, please.
Hi, my name is Erin. I work in the clinical trials office. I've been with the Cancer Center for about 9 years now in the CTO. I just wanted to confirm that unfortunately we do not have any local sarcoma treatment trials available, but I wanted to also make a plug. We have a lot of symptom management, cancer control, clinical trials. There's a lot of different types of clinical trials outside of, you know, just looking at treatment A versus treatment B. So I wanted to make a plug for that, make sure patients know to ask their doctor, even if there's not a treatment trial, is there anything that can help me with my pain? Is there anything that can help me with my neuropathy that I'm experiencing because of treatment? Because there are those types of clinical trials out there as well. And also, as another plug, do not fear clinical trials. It is a completely voluntary process, and we appreciate every single one of our trial patients' support and the time that they dedicate to participating. It's that type of you know, commitment and effort on their part is unmatched. And I just want to say thank you to all of those out there, even just listen to me right now talk about clinical trials. Thank you so much for your time and having an open mind about it. We're always here to support you. Being on a clinical trial can be a great experience. So I want everyone to maybe approach it with an open mind, and also know that we're here to not, you know, experiment, or we really are here to help and to, you know, get to the same place, to a cure, to helping patients live better lives post-cancer. You know, whatever your goal is, we want to help support that. Thank you.
Thank you, Aaron. Oh, sure, go ahead.
Very brave today. Thank you. This thing. Okay. Hi, Anna Quinn, clinical trials office. And I just wanted to say, yes, clinical trials, they're limited right now and what we can provide. And we realize that in the healthcare community, we are working very hard to open up an early phase center. Which will open in about a year on our campus here, that we will be able to provide additional trials to what we already can provide now. So we're very excited to do that. And that's all I have to say today.
All right, thank you. So I would just want to wrap up. I want to be respectful for everyone's time. It's 7 p.m. But again, I do want to thank everyone for being here. We have famous politicians here, Barbara Maramoto. We have any questions regarding the Department of Health. We have Dr. Libby Char, who's in the audience, who's kind enough to join us, so she can answer all your Department of Health questions later and cancer clusters. But really, all kidding aside, thank you so much for all the work that you've led us through the pandemic, and we appreciate what you did for our state. And I just again want to say thank you for all the different partners, all the marvelous speakers, Dr. Wu, Kelly, Mr. Kikua, Ms. Huff, Wendy Sweet, Miss Sweet, amazing story, so touching, Dr. Hernandez, and just Dr. Ueno for supporting this endeavor. Sometimes when you ask a question like, when you're a kid, the answer is not always yes. So, but I really wanted to say thank you for him buying in. And as many of you, as I said from the outset, some of you may have joined late, Dr. Ueno, who's a director here of our UH Cancer Center, is a sarcoma survivor. And so that is something that he feels is very personal. And so thank you for all of you for taking the time, for being here, joining online and in person. Again, shout out to Michelle Hashimoto, who I really put a lot of work, and Esme Infante and all the team at UH Cancer Center, and my team over at Queens, and the folks that Dr. Kelly works with at Tripler, and Dr. Wood, HPH. Again, all these brave folks here to share their heartwarming testimonies. And this is something, again, my wife would say, what makes Hawaii so special is our essence of aloha, that we can come together on a Wednesday night and build something. So thank you so much. God bless all of you, and I hope you drive safely. Thank you.